Okay, so we'll start. Tēnā koutou, welcome to our second webinar for 2022. My name is Lucinda Thatcher and I will be facilitating this session on inflammatory bowel disease. I would like to introduce Professor Richard Geary, an IBD specialist and gastroenterologist from Christchurch. We are very privileged to have you speaking to us this evening, and we look forward to enhancing our knowledge in IBD and learning many tips and tricks to help our patients with IBD. This evening is supported by the Rural Health Department of Otago University and the Rural Hospital Medicine Division of the Royal New Zealand College of General Practitioners. We can claim 1 hour of CME for tonight's session, and if you'd like me to lodge these points for you, this is possible this evening after you have completed the feedback form and documented your New Zealand Medical Council number at the end of that form. I'd also like to take a moment to thank Richard Geary for helping this evening. If you have any questions throughout the evening, please post them in the chat and we will stop after each case and ask these. All that said and done, I will now hand over to Richard Geary and again, just thank you very much for joining us this evening.
Thanks, Lucinda, and thanks for inviting me to come along this evening. It's always a real privilege for me to talk to other doctors about what I do, but also try and work out how you do what I do in places where you are, which is very different to where I am. So hopefully we can meet somewhere in the middle and understand how we can look after our IBD patients really well. So tonight I'm going to do a little bit of an introduction and then there'll be a number of cases. During the cases, I'll stop and I'll throw some questions out there. And what I'd like you to do, if you can, is maybe just make some notes down about what you think the answers might be. And then we'll go through those as we go. So if you just sort of test yourselves on those as we go, and then there'll be more chance for questions along the way as well. So people often think that my life's a bit like this. It's about looking down pink tunnels, which enable me to get a good view of the world. This is a colonoscopy movie, which might play in just a moment. There we go. Beautiful reticular pattern of blood vessels there. We call that the Toblerone sign. It's the transverse colon. It's a triangle. That looks really healthy and good. And that brings joy to my heart when I see a colon like that. Fantastic. However, if you've got ulcerative colitis, you might have a bowel that looks like this. You can see the white ulcers there. And then there's these islands of existing inflamed tissue. And obviously that's someone with a pretty sick colon there. And what's more, if you had Crohn's disease, then you might have a colon that looks like this, where you see patchy inflammation and a stricture coming up just here as well. So you can see they're sort of real diseases that look pretty bad. They can affect people in all sorts of ways, and that's what we're talking about tonight. But of course, IBD just isn't in your bowel. Just to remind you that a lot of people with inflammatory bowel disease have extra-intestinal manifestations, and that can include erythema nodosum, which you can see there on the shins, but can occur anywhere on the body. Obviously, red, painful lumps that then fade to a bruise. Pyoderma gangrenosum, which is rare, but we can see again on the calves. On the shin, sorry, and also around the stomas, sometimes people can get pyoderma gangrenosum that can be quite challenging to manage. We can get peripheral arthritis, we can get a central or axial arthritis, similar to ankylosing spondylitis as well, and this can go with the disease at the same time. And then we can also get bile duct lesions affecting the bile ducts, leading to sclerosing cholangitis or cholangiocarcinoma. And then many of you will be aware of patients with Crohn's disease also having perianal fistulae and abscesses, and that can be really pretty difficult for patients with those sorts of diseases. So obviously it's not just in the gut, it's in other places as well. So before we go any further, who gets IBD in New Zealand? Who are these people? I've done some pretty cool epidemiology studies here in Canterbury, and that black line is the incidence of Crohn's disease in Canterbury. We've got one of the highest incidences anywhere in the world. And we know that in other places around New Zealand, the incidence is also high, perhaps not quite as high, but certainly high. So there's a lot of new people being newly diagnosed with Crohn's disease all the time. I think in Canterbury, there's about 3,000 people. So it's getting up towards, about 0.7% of the population probably. If you look at the sex and age of onset, again, you can see that people are diagnosed between 15 and 45, roughly for Crohn's disease and ulcerative colitis. So that's the peak age of diagnosis. But of course, we have children and older people being diagnosed as well. Why do they get it? That's a whole other talk for another day. Lots of reasons why there might be. Whenever there's lots of reasons, I always tell the medical students it means we don't know. And I think we've got some ideas, but we don't really fully understand why people get it. But it's essentially a dysregulated immune response in a genetically susceptible individual. All right, so that's enough of me talking about the background stuff. What I'm going to do now is run through these 4 cases, and we'll stop along the way and we'll be able to talk through what's going on and where we're going. So the first patient is a 22-year-old lawyer called Sean. He presents with some abdominal pain, increasing severity. It's probably more on the right side than the left. He's had a few loose bowel motions. He's had a bit of nausea and anorexia, and he must be sick because he's a lawyer and he's had 2 weeks off work. In the background, he smokes and he's had some asthma as well. That's most of the history you get. So just if you take a moment now, just to think through these 3 questions. So firstly, what could be causing this man's symptoms? Now, this isn't IBD talk, so you can put IBD down as number 1 and you're probably going to do pretty safely, but just think about what the other differential diagnoses might be for a young man presenting with subacute symptoms of this sort. And with that in mind, as you think about those differential diagnoses, just think about what other history might be important or useful, what other things do you want to know, and then what tests might you request? And I understand that we don't all work with a huge lab straight across the road that goes 24 hours a day. So what might you do where you are that could be helpful to try and understand what might be going on for this young man? So let's give you a little bit more time to think about those 3 questions, and then we'll move through the answers. Okay, so what could be causing this man's symptoms? So this is the differential I put down. So Crohn's disease, because obviously this is an IBD talk, so we've got to have an IBD case, at least one. So there's that. Celiac disease can present this way as well. Remember, it's about 1 in 70 of the population of New Zealand probably have celiac disease. So there's a lot of undiagnosed celiac disease out there. Your gut infections, Giardia in particular, other gastrointestinal infections. IBS, 1 in 6 women, 1 in 9 men have IBS, and it can manifest itself in different ways. Remember drugs that can affect the gut, so anti-inflammatories, they're the bane of my life. I know they're so good for musculoskeletal pain, but not only do they cause stomach ulcers, they can cause enteropathy of the small intestine or the colon, which is just like IBD. It could be a subacute presentation of appendicitis. He could have something more uncommon like cancer or diverticular disease, but that'd be the sort of things I'll be thinking about straight up. So if you're thinking about, well, how might I go about working out what's going on? What other history is important? Again, history is so important in much of what we do in medicine, certainly in gastroenterology. I think it's the key thing. I'd much rather have a history than an examination any day of the week. So the pattern of symptoms. So for something like IBD, it just keeps on getting worse. So I know it's relapsing and remitting, but that's usually over weeks to months, but generally it just keeps on getting worse. Whereas IBS will go to sleep when the patient does and wake up again when they do in the morning. People will be awake with their symptoms of IBD overnight. Rectal bleeding, of course, is going to suggest a more organic pathology. Weight loss the same. And then have there been any infectious contacts, any drug use, smoking? So as the patient a smoker, we know this patient is, so that increases the risk of the patient getting Crohn's disease. But if it was someone who was a smoker and stopped smoking, that increases their risk of getting ulcerative colitis. So that association of symptoms with starting and stopping smoking is important. Of course, any family history of gut problems is important. So celiac disease, IBD, colorectal cancer, that's all important to know about. And of course, you can ask about these extra intestinal manifestations of inflammatory bowel disease, those things I showed you earlier. One of the things I often ask about is mouth ulcers. So the mouth is part of the gut, and often patients will have significant mouth ulceration that might just increase your thoughts about that being the case. So what basic tests might you request in this person presenting for the first time? So the things I've thrown out there are a blood count, some celiac serology, a CRP, fecal culture and parasites all the time, really important to check for. Calprotectin, it's the bane of my life. We're going to talk a bit about calprotectin tonight. It can be such a good test, but usually it's usually not. It's usually requested when it's not needed. Iron studies, B12 and folate to think about absorption and liver function for some background as well. So the reason I say calprotectin can be a problem is that, remember, anything inflammatory can put your calprotectin up. So if you had an infectious gastroenteritis, if you had anti-inflammatories on board, if you had inflammatory bowel disease, they will all put your calprotectin up. And at the end of the day, all you want to know is the calprotectin elevated or not? And can you, so is there inflammation there or not? And if the CRP is elevated, you don't need a calprotectin. So remember, I always say the calprotectin is a second line test for me. It's something you do if you don't have objective signs of inflammation elsewhere or no other cause for them, then a calprotectin can be helpful, but probably not first line. So Sean has a few tests. He's referred to a gastroenterologist and here's a colonoscopy. He's got a bit of inflammation in the colon, but a bit more inflammation in the terminal ileum. So that's what the ileum looks like. It's a bit red and pink. There's that mucus exudate over some ulcers. And we send off a pathology slide. We send off a biopsy, and there's a beautiful granuloma at the top, which we prepared earlier for you. Only about 20% of patients have granulomas. So Crohn's disease diagnosis is made. So how do we assess IBD? Obviously, the history and examination are important. How bad are the symptoms? The lab markers for inflammation. And then when we want to make a diagnosis, these patients need a colonoscopy to make the diagnosis. Sometimes they need a capsule to look at their small bowel. Cross-sectional imaging can be important, especially if someone presents sick at the start and you're worried about surgical problems. And then gastrointestinal ultrasound is something that's evolving and I thought might be of interest to many of you who use ultrasound. So we can, of course, look at the gut as well as other organs in the abdomen. And in fact, usually most people doing ultrasound of the abdomen are trying to get away from the gut and the gas patterns that it can interfere with. But we can actually get beautiful pictures of the mucosa, the submucosa, and we can look for thickening and stenosis and fistulae can all be picked up on gastrointestinal ultrasound. Here you can see Doppler flow as well, looking at how inflamed something may be. So again, there is a learning curve to this. It's not something people can usually pick up straight away, but certainly ultrasound can give additional information in the right hands and can be used in that way. So you've now got this young man, he's got Crohn's disease, mostly of the ileum. What treatments might you consider? So again, just take a moment or two to think through a new diagnosis of Crohn's disease. He's having a bit of a flare at the moment. What might you do to get him well? So the things that I would think about in a young man, he's got moderate to severe symptoms. He's a lawyer who can't work, so he's probably quite unwell. So to me, he probably needs a course of steroids. I'll talk a bit about steroids later on. Steroids are amazing. They are so good, but they are so bad as well. So they're a great drug to get you well. They're not a good drug to keep you well. So if you start steroids, you must have an exit strategy. This man's going to end up on an immunomodulator like a thiopurine, azathioprine, 6-MP, thioguanine, which we use increasingly now. But we'll probably start that in gastroenterology, and also biologics subsequently, if he fails those, would be the sort of things that we'd be thinking about. So despite having some treatment, he carries on having symptoms. He turns up at an ED with abdominal pain. So this could be anywhere in the country. He's got a new diagnosis of Crohn's disease, turns up with abdominal pain. So what tests would you do for this young man? You know he's got this diagnosis, he's got pain, you take a history, you need to find out what's going on, what's happening with inflammation-wise, what could you do, what would you do? So to me, when you get an acute presentation of someone with inflammatory bowel disease, obviously you need to determine, could they have a surgical problem, a perforation or an obstruction, and that will be determined clinically, but a very low threshold for a plain X-ray if you can do one. I know that everyone can't do one, but that can be helpful in that situation. And again, in a place where I can get lots of tests, I'll be looking at getting a blood count done. And again, with an iStat, you can get some of those things done. Some electrolytes can be helpful. Any markers of inflammation would be good. And even in a fecal spec, you're not going to get the answer straight away, but that could be helpful too. So other sorts of things we'd be thinking of doing early on. If we're worried at a big hospital, we'll run them through the scanner. If they go to the surgeons, they're going to get run through the scanner anyway. So, but if the symptoms aren't that bad, but if there's any concern about a surgical problem, perforation or obstruction, then they need to get to a base hospital. So just some sort of broad discussion about Crohn's disease treatment. These are sort of the key features I think about how we might manage Crohn's disease. So for both Crohn's disease and ulcerative colitis, we have an anchor drug, which is the key drug that we use. And generally they are thiopurines for Crohn's disease. So the thiopurines are azathioprine, 6-mercaptopurine, and increasingly now we use thioguanine, which is sort of at the end of the pathway, and it can be used very effectively, and we use that a lot. Methotrexate we use a bit as well, but we tend to not use it as much because we have a lot of women with Crohn's disease, and of course methotrexate is a major issue around effects on the fetus. The 5-ASA drugs like pentase and azicol really don't have much of a role in Crohn's disease. Maybe if you've got some colonic Crohn's, but they really don't do that much. So we tend not to use them. In saying that, they are prescribed a lot, but there's not a lot of data to support them. The problem we have, of course, is that the immunomodulators have got toxicity. The 5-ASA drugs are pretty well tolerated. So we like to use things that are safe, but if they don't work, it doesn't really add up. So steroids, as I mentioned before, are absolutely very good at getting people well, but very bad in the medium to long term. So they're used to induce remission from moderate to severe disease. Orally, they're given as prednisone, but we can also use budesonide, which is we can give on a special authority, but we're always happy to provide those for others. So budesonide is released in the distal ileum, and it's got a very high first pass metabolism. So you get most of the benefit of the steroid with less side effects because it's metabolized on the way through. And if people are really sick, they need admission to hospital for IV steroids subsequently. What about biologics? So these used to be the new drugs. They're not anymore. They've been around for a long time now. So these are the drugs that we use when the thiopurines don't work or patients can't tolerate them. And the two that we have in New Zealand are both anti-TNF drugs. It's infliximab and adalimumab. Infliximab, also known as Remicade, is given in small hospitals, large hospitals, infusion centres all around the country. Adalimumab, you'll know, is Humira, but now it's been changed to Amgevita, which is a biosimilar. It's essentially the same drug. It's just much cheaper for Pharmac now to buy, which is good. Hopefully they can give us some new drugs if we're lucky. And there are many other drugs we'd like to get, but they're the two that we have access to at the moment. But Amgevita, I'll talk about a little bit later. It's essentially the same drug, but you can use it in different ways now with the new special authorities. Exclusive enteral nutrition, so formula by itself is fantastic for inducing remission, especially of small bowel Crohn's disease. It's fantastic and it has few side effects. It works really well. It improves nutrition as well. The problem is that having patients drink formula and nothing else for a number of weeks can be quite challenging. So it can be something that can bridge someone over. It can be used instead of steroids, but the patient's got to be highly motivated to do that. And then, of course, don't forget the low-hanging fruit. A lot of these patients are iron deficient, B12 deficient, folate deficient, and we can correct that stuff as well. So when I think about Crohn's treatment from a medical point of view, they are the things I tend to think about. There's a whole lot of other stuff we can do diet-wise. Obviously, surgeons play a big role. Psychological therapies are important as well for a lot of these patients, but these are the key medical things that I'd be thinking about. So back to our lawyer. He has a colonoscopy, and that's his ileocecal valve, which is now very narrow. So what we did for that is we dilated it. So we did a colonoscopy and put a catheter down and stretched it up. We felt very clever and smug after that, and that was fine. So this is a new diagnosis of Crohn's disease, and just summarising this case, the history suggests the site of inflammation. It was in the ileum, and pain and diarrhea were the key features with some weight loss. The simple test can frame the referral for colonoscopy. So if there's abdominal symptoms with signs of inflammation, be that CRP, be that a mild anemia, be that raised platelets or low albumin, all those things are suggesting inflammation, can help us get a colonoscopy. Crohn's disease will progress over time. So the reason we treat it isn't just for the symptoms, but if we don't treat it, you get scarring, and that can lead to strictures and fistulae and abscesses, and patients then will end up with surgery, which we want to try and avoid. And immunomodulators are the anchor drug. So I'm going to stop there, and I'm happy to take some questions at that point.
So I've just got a couple of points before you start, Rich. So just to clarify, your definition, I'm going to guess, of cross-sectional imaging is CT, isn't it?
Correct. Yep. Yeah, it is CT, yep. And I know that everyone doesn't have that, but I suppose that's one of the real key decision points if you're in a smaller place, that, you know, when do you need to ship this patient out? And I suppose that's where the conversation with the surgeon at the base hospital comes in, being able to, you know, understand whether the patient's peritonitic, whether the patient is unstable, where they could be going. I think having a good relationship with those surgeons is important.
Interestingly, I asked in the chat, Richard, about CRPs, point of care testing, and people do have that, so that's good to know. Just around initially in your diagnosis, you just called this Crohn's and you didn't include ulcerative colitis. Can you just clarify how you could narrow that down?
Yeah, so the history gives you so much about where the problem is. So for Crohn's disease, typically abdominal pain, if it's small bowel Crohn's, abdominal pain, diarrhea, weight loss. So it's just the small bowel symptoms. Whereas if you have ulcerative colitis, you have rectal symptoms, you have urgency, you have diarrhea, you have incontinence, you have rectal bleeding. So that they're quite different in many ways as to how that could look. Now, of course, you know, Crohn's disease can also affect the colon, so you could have colonic symptoms the same way, but you do get a real feel for the symptoms based on where the inflammation is.
Good, thank you. And then just to clarify, what would be your definition of failure of treatment with thiopurines? What would stimulate you to go to the next step?
Yeah, so as a gastroenterologist, we want to make sure firstly, are they having enough, so that, and have they had it for long enough? So the thiopurines take at least 3 months to work. So if someone's prescribed as a thiopurine and they're a month later, they might just need some more steroids to bridge them through to getting them working. So firstly, have they been on it for long enough? And secondly, have they had enough? And we can measure the metabolites of thiopurines. So 6-thioguanine we can measure in the blood, and there is a therapeutic range for that. So again, that's something that can be done to determine whether the patient's getting enough drug or not. I'm not going to go into all the pharmacokinetics and pharmacogenetics tonight, but certainly we can use those parameters to determine whether the patient's had a sufficient trial.
Brilliant. I'll hand over to you, Rich.
Cheers, Lucinda. Hey, Richard. At the beginning, you said, I mean, this is the acute presentation of somebody with a new diagnosis of Crohn's disease. And I think this leads into the next case, but what sort of other differentials would you have had initially in this case, beyond, of course, inflammatory bowel disease? And the specific question from Jeremy up on Taupo was, is it unreasonable, you know, like, could this be diverticulitis in a 22-year-old, or would you have felt that was a bit young?
It's pretty young. I mean, I'll put it on the list, but it'll be low down. So I think it would be unusual. I mean, obviously, I always tell the patients when we do colonoscopies and we find diverticular disease, I say, yeah, as we get older, we all get them. But the problem is that if I did scopes on everyone in the community, they'd all have them and they don't have symptoms. So usually they're an incidental finding. But of course, we do see occasionally diverticulitis in a young person, and in those middle ages from probably 40 onwards, you're starting to get a bit of overlap at that point. But it's probably going to be pretty rare, in the same way that a cancer in this person will be rare without a family history. But, based on their symptoms, they need a colonoscopy, and you'll answer that question either way.
Thank you. And then in your practice, do you find that using ultrasound is useful sort of with acute management of IBD, or the images that you put up, were they more for interest, or if you didn't have that same access to investigations as you do in the tertiary hospital?
Yeah, so we'll use it instead of MRI, usually in the more elective setting where we want to stage someone's disease. But certainly, if someone was confident with with ultrasound or wanted to learn more about that, then it is something that can be done. The issue will always be, it's easy for us, we've got 3,000 patients in Christchurch, to have someone who's a specialist gastroenterologist who can do that ultrasound work. But it's about whether someone who's got the ultrasound skills can upskill in that way. So it's probably done more in the subacute setting.
Well, seeing that we're on to people with ultrasound skills, Matt Bourne down in Central Otago, he loves ultrasound probes, and he had a specific question, which was why the stool culture on the second presentation for someone with Crohn's? Yeah,
so people with inflammatory bowel disease are more likely to get infections than people without inflammatory bowel disease. And the bane of my life is trying to understand why someone's presenting with symptoms who's got known IBD, because they could be presenting with diarrhea because all of a sudden they have picked up Campylobacter. They could be presenting because they've got coexisting IBS. So 50% of Crohn's patients have IBS as well as Crohn's, a third of UC patients. So you get these dual pathologies going on. And of course, I don't want to throw a whole lot of steroids at someone who has got Campylobacter. So every time someone flares, they get fecal samples done. And if you start steroids and then it comes back, that's fine. You can stop them. But if you don't look, you won't know. So it's such easy tests to do. I always have a low threshold. And also going back to the history, typically the patient with Crohn's disease who all of a sudden has a sudden onset of diarrhea and abdominal pain. Well, if it's a sudden onset, that sounds much more like an infection. So it's not that thing. You've got Crohn's, you've got diarrhea, you must be having a flare. It's listening to the history and understanding, actually you do have Crohn's disease, but gosh, that doesn't sound like your normal flare. That sounds like you've got gastro. So low threshold for thinking widely for other diagnoses.
Having previewed this last night with you, Richard, I know we're going to move on to that shortly. So for David Short that was asking, I don't know where you're in the country at the moment, David, he wanted a little bit of support about having to identify, other differential diagnoses, but between himself and Jack Hayward, wherever he is in the country at the moment as well, they were saying about, well, you know, if you were going to go and see a gastroenterologist in the meantime, you're going to start them on steroid. You know, what did you have in mind, Richard, and for how long?
Yeah, so we will talk about steroids coming up, but generally, I mean, you saw what the bowel was like at the start of the presentation. You know, there's a lot of tissue inflammation there, so it needs a lot of steroids. So for us, it's 40 milligrams a day for a week, reducing by 5 milligrams per week. So I give them 8 tablets a day for a week, 7 tablets a day for a week, 6 tablets a day, 5 milligram tablets, and just do that. And I say that I do that because I can't do the maths of adding 20s and 5s together, because I'd get that wrong. And if I'd get it wrong, I think the patients have got a chance of getting it wrong as well. So it's a lot of tablets, but if you explain it's a small denomination, it works fine. And that wean is a standard wean that we would use over time. And of course, you want to see that people respond. And if they don't respond, then they may need IV steroids.
Thank you, Richard. Well, shall we move on with the cases?
Sounds good. Okay, so here's Petra. She's an 18-year-old GAP student. This must be old slides because there wouldn't be any GAP students around at the moment. But anyway, she's had 2 or 3 weeks of rectal bleeding with lots of diarrhea. She's had to get up at night to pass her bowel motion, and she was incontinent once. It wasn't much fun. She did go through Asia not long ago. This was about 3 years ago. And she's also had a knee injury recently, and just pops a few diclofenac now and then. So similar questions. Before we go into those, I just want to throw this slide up because this is my approach to gastroenterology on one slide for luminal gastroenterology. Whenever you know the red flag symptoms, I'm always asking about it. Any weight loss, any onset of symptoms in old patients, because it could be cancer, any family history of cancer or IBD, any symptoms that are unremitting. You know, functional symptoms come and go, but severe symptoms don't. Rectal bleeding needs an answer, and nocturnal symptoms, because nocturnal symptoms suggest there's something organic going on. Now my key red flags that I look for, and then with regards to examination for IBD, a fever or a mass, and look at the bottom, have they had an abscess before or a fissure? And then for the lab testing, I've gone through those as well. So what could be causing this woman's symptoms? What other history would you think about? What basic tests would you request? So again, I'll just give you a moment to think through those things before we go through them. So just have a think yourselves. You know, young woman, different symptom complex to the first patient. What else would you want to know about, and what other tests? Okay, so what could be causing this woman's symptoms? Pretty similar differential diagnosis, really. But this time you've got a history of a drug that could be doing the problem. She has had gastro while traveling in Asia, so she could have a post-infectious IBS. So 1 in 6 people who get gastroenteritis, like Campylobacter or rotavirus, whatever, will get ongoing gut symptoms despite the fact the bug is gone. So post-infectious irritable bowel syndrome, 1 in 6 people. And you again, it's in the history. There were very sudden onset of symptoms that they can say, I was well, and then on that day I got sick, and then it was like I had gastro and never got better. And that's post-infectious IBS, which could potentially be the case. Although here you've got those alarm symptoms going on of nocturnal symptoms, of incontinence in a young person, and rectal bleeding as well. What other history would you ask about? Again, more detail about the symptoms. And then these other things as well. They're the same things as the last patient, about weight loss, any infectious contacts, the drugs again, the family history of any of those things we worry about, any extraintestinal manifestations, including mouth ulcers. And what basic tests, again, similar to last time, blood count, CLEC tests, CRP, fecal culture, Calpro, if the CRP was negative, iron studies, B12 folate. Okay, so the patient finds a gastroenterologist, and here you can see a different pattern of disease. They've got continuous disease starting at the anus, moving proximally, and they've got crypt hyperplasia and branching there with an inflammatory infiltrate. So again, what diagnosis, what treatments, and what might you consider if things start going badly? So again, just have a moment or two to think about that. We've got the diagnosis, I think. I've given you that one. So what treatments are you going to use for someone with with UC? What are our key drugs here? And if she deteriorates, what are we going to do? Okay. So what diagnosis would you make? It is consistent with ulcerative colitis. And again, I mentioned earlier, you can ask about the onset of symptoms. If someone just stops smoking and then they develop gut symptoms, then ulcerative colitis is high up on the differential. Patients who have got IBD can have their disease worsened by diclofenac or any anti-inflammatory. So again, you need to be careful treating pain in IBD. It's a really challenging situation because paracetamol is fine, but it's not that effective. Codeine's constipating, tramadol also constipating, and anti-inflammatories can make their symptoms worse. So pain relief in IBD can be challenging. Infection and IBD can coexist, and sometimes we do need to treat both together, but you've got to go looking for both. You need to do the fecal sample. So what treatments would you consider? So in ulcerative colitis, we love 5-ASA drugs. We love sulfasalazine, pentasa, azicol. They are our go-to drugs, and they are the anchor drugs. And we know that they're really good to induce remission. We also know they're very good to maintain remission. And we also know that if they use long-term, they probably reduce the risk of colorectal cancer in people with ulcerative colitis. So there's lots of really good reasons to stay on those drugs if people can tolerate them, and they usually can. Now, the other great thing about 5-ASA is that we can give them 4 different ways. We can give them as tablets. We can give them as sachets if people have struggled to swallow the big tablets. We can give suppositories, and we can give enemas. And for people with distal disease, rectal 5-ASA is a wonderful, wonderful thing. And if patients can get over the fact that they have to put something in their bottom, if you can tell them that, we put this drug in, it's right beside where the inflammation is, it works really, really well. And what's more, if someone's sick with on oral 5-ASA, you can add rectal 5-ASA on top, and it's additionally benefit. So you get double bang for your buck, if you like, with both deliveries. And if people are sick, they can get prednisone. And again, it's that standard wean of 40 milligrams a day for a week, weaning by 5 milligrams a week. Continuing with the 5-ASA, we add drugs on top sequentially to try and get them under control. So ulcerative colitis treatment, 5-ASA is the anchor drug. It induces and maintains mild disease. It can be used orally, topically, or both. And the other thing is that patients often have been prescribed their 5-ASA 2 tablets 4 times a day, or 4 tablets twice a day. Once a day dosing is just as effective, probably more effective because people remember it, than split dosing through the day. So if you've got patients who are on split dosing through the day, they can take 8 pentasa or 4 pentasa, whatever they're on, all together at once. It works just as well. So they'll thank you for that. Steroids, again, induced remission, really important. Immunomodulators, only the thiopurines. Methotrexate doesn't work. Biologics, infliximab certainly is effective, and now with Amgevita, you can use Amgevita for ulcerative colitis now. You didn't used to be able to use Humira, but now you can use Amgevita, and again, that micronutrient replacement. So steroids, as I mentioned, they're the devil we know. I always tell my registrars, if you start a course of steroids, you must tell me your exit plan. You cannot start steroids and just say, have some steroids and we'll see how things go. It's just not good enough. You've got to have a plan on the way out. And in the hospital for us, it's obviously often bridging patients to an immunomodulator or bridging them to a biologic. But I think in primary care, it's actually telling the doctor, telling the gastroenterologist that this patient's having a course of steroids at the moment, and can they catch up with them? Can they come give some advice? Can they come up with a plan? Because it's so easy just to slip into these recurrent courses of steroids, and before you know it, people have had a lot of steroids and a lot of potential side effects. And patients can really, you can lose your therapeutic relationship if they, a lot of these are young women, and you're giving them a drug that makes them put on weight, gives them a round face with acne, and makes them moody. So it's a pretty hard sell. So if you can tell people, look, it's going to make you better, but we've got another plan, it becomes really important. And what's more, all these drugs are immunosuppressing, and as we combine them, the risk of infection goes up as well. So it's important to think about that. So if she deteriorates, she might be in trouble. So 1 in 6 patients with ulcerative colitis will have a flare with acute severe colitis requiring admission to hospital. And those people have got a high risk of losing their bowel, and they've got a risk of dying as well. And then back in the 50s and 60s, before steroids, this was often a fatal disease. So these patients are hospitalized and they have shared care, and we like to see them early. We like to know about them early because we can get on and get their treatment up and going. So these are the Truelove and Witts criteria, and I just want you to concentrate on the right side. And these are the things you should be looking for in someone with ulcerative colitis. These are the patients who need IV steroids, who need to be at a centre where there's a surgeon. So if they get worse, they can have a colectomy or they can have a biologic or whatever they need. So that's greater than 6 bowel motions per day, significant bleeding, a fever, signs of toxicity, so a tachycardia, a significant anemia, and also a CRP that's up. So if you look at those and you start to think about what that means, if you've got acute severe ulcerative colitis with positive Truelove and Witts criteria, your risk of a colectomy is significantly greater. And yet these are all independent predictors of a colectomy. So identifying those patients, looking for those systemic markers of temperature, pulse, hemoglobin, CRP, rectal bleeding, and frequent bowel motions more than 6 times a day. They're the things we need to be thinking about. And that's what I'm listening for when I take a phone call from a GP about someone with a colitis, because they're the things that will help me make my decision. When we admit someone, here's my alphabetical approach to how I manage acute severe ulcerative colitis. Now, some of you may need to start doing this in the centres that you're in before you transfer them. So the first thing is admit the right people. So they're the Truelove and Witts criteria I've just shown you. You don't need to know what they are, but who they're named after, but just understanding that people are sick. Then B, they need blood, fluids, electrolytes, nutrition. So that's that sort of rehydration or resuscitation, if you like. C is the colorectal surgeons and steroids, corticosteroids. So they get IV steroids, 100 milligrams of hydrocortisone 4 times a day. And we consult the surgeons on day 1 so they know they're in, so that they can review them every day with us and make sure they get better. People with severe IBD are at high risk of getting DVT PE. They die of PE. So they need prophylaxis. And we need to stop the drugs like the Imodiums and the codeines and the anti-inflammatories, which can make things worse. Some patients can have infection at the same time. They can have C. diff. So again, even though this person's clearly got UC, we always are looking for super infection because we can treat that. And then we assess them frequently and make a decision about a biologic on day 3. So that's what we do. So if you send them to us, that's our approach. And you can be doing some of those things yourselves with low dose, low molecular weight heparin for some of these people, getting that on board. Maybe you can give the first dose of steroids where you are before you transfer them, making sure they're well hydrated and doing those sorts of things. So this is what can happen when things go wrong. One of the worst complications, but one of the coolest names in medicine, toxic megacolon, can occur where you get dilatation of the colon. You get thumbprinting. You can see on that transverse colon there. So just for UC, the case summary, remember the symptoms suggest the location of inflammation. Other causes of inflammation can be common, anti-inflammatories, infection. Think about markers of severity. And 5-ASA are the anchor drugs, but steroids are fast and effective, but you've got to have an exit strategy. So I'll stop there.
Brilliant.
No, I've got one more slide. So this is I don't know why I put it here, but this is when you've got a patient and they're already on lots of treatment. What can I do when they're sick? So if someone's on 5-ASA, you can increase the dose. If they've got UC and they're flaring, you can increase the dose up to 4 grams a day and add rectal therapy on top. So it's easy enough to do. You could start an immunomodulator, but that takes weeks or months to work. So it's not going to get you out of trouble immediately. And that decision is really probably a specialist decision, I think. You can use Amgevita, which is the new Humira, if you like. And what you can do now, in the old days, if we wanted to use Humira weekly, so usually Humira is given 1 injection every 2 weeks, we could apply to the company for a compassionate supply for 6. But now with Amgevita, you can just push someone up to weekly Amgevita straight away. So if I had someone who came to see me rurally who was flaring, I'd be quite happy if they're already on Amgevita, just to put them on weekly for a while they're waiting to see the gastroenterologist. So that's something you could do instead of steroids now, which we didn't really have that option in the future. The special authority is still valid. You just have to change them to weekly. So that's something you can do now, which is a new thing. Infliximab, we can increase the dose up to double dose or give it more often. We can give exclusive enteral nutrition. So you can put them on a formula feed, but they often need a bit of dietitian support for that. That can be done remotely, but it's just a matter of finding that person to do it. And then antibiotics, sometimes things like metronidazole, particularly for perianal disease, can give us a small effect as well. So here are some tips and tricks for how you can potentially get better value without just giving steroids. You can increase treatments that people are already on or add some other things in. Right, I'll shut up now, Lucinda, all yours.
Oh no, there's just so much good stuff. In fact, that simplicity of Pentasa once a day, I think could be life-changing. Can I just quickly clarify, you mentioned about stopping smoking and getting a flare up of UC presenting? Is it that way versus starting smoking? That's the stopping.
Yeah. So for smoking, so the key is don't start, because if you start smoking, you might get Crohn's, and then if you start smoking and stop, you might get UC. So, so if you have Crohn's, I tell my patients with Crohn's that I'm really excited that they're a smoker. I know it might have given them the disease, but what it means now, if they stop smoking, it's probably as effective as any single drug I can prescribe them. So all of a sudden, because they're a smoker, I've got a whole new treatment I can give them, which is smoking cessation. I tell them I don't care about their risk of lung cancer, heart disease, stroke, etc. All I care about is their Crohn's disease, and let's stop having diarrhea and stop smoking. So I really push that very hard. That smoking cessation message. But unfortunately, for some patients with UC, it can make their disease worse. And some people will restart smoking with UC to try and control their disease. So we work hard, obviously, to get them off that if we can.
I could say some very cheeky stuff about being a siloed gastroenterologist there, couldn't I?
Yeah,
and then just going back to we had a wee discussion last night about drug cessation and the reason around stopping the loperamide and codeine, which seems very simple, but if you can just highlight that point again.
Yeah, so if your bowel is so you saw that movie at the start of that person with ulcerative colitis, the mucosa is sloughed off. So that bowel is thin and it's full of inflammation. If you all of a sudden stop the bowel moving in that situation with loperamide or codeine, that person will perforate. They will have a spontaneous perforation, and that's a disaster. That's potentially fatal. So while it sort of is so easy for patients, I'm having diarrhea, I'll just pop some loperamide, that's sort of okay, but I'm always a bit twitchy about it, especially if there's signs of inflammation going on or they've got significant colonic inflammation. It's a big deal. So you can use those drugs, but you've got to be very, very careful, and certainly opiates extremely careful of as well.
Great. Now, just around CRPs, ESRs, and calprotectins, I mean, we tend to not, I say that ESRs and the Truelove and Witts, I suspect that's quite historical, and you can now just use the CRP.
Yeah.
How often would you get a negative CRP and a positive calprotectin?
Yeah, good question. So that's when the calprotectin is really helpful. So calprotectin is super sensitive. So it will go up really easily. And there are a lot of people out there with positive calprotectins that don't have IBD. So it's a bit like your D-dimer. It's a great rule out test. So if someone's presenting with diarrhea for the first time, their CRP is normal, you're still worried about IBD, you do a calpro. If it's less than 50, they're incredibly unlikely to have Crohn's disease or ulcerative colitis. Incredibly unlikely. So it's really good as a rule out test. If it's elevated, it just means they need to have the next test done. Which may be a colonoscopy or maybe some other things. So it isn't perfect, and certainly, but it can be very helpful in that situation. The other situation it can be helpful in is if someone has got IBD and they're having symptoms all the time, and you're not sure are they having their coexisting IBS, and you can't tell from the history. You don't want to colonoscope them every time they come in, or they won't come back to see you anymore. So a biomarker in that situation, if a CRP isn't helpful and the person does throw a calprotectin, then that can be a helpful marker in that situation as well, to try and understand, is there any much in the way of residual inflammation going on.
I mean, you say over 50, but I had a guy with salmonella gastroenteritis, and he had a calpro of 800.
Oh yeah.
So,
easy. Yeah.
I mean, that's still significantly elevated.
Yeah. So remember for those patients, once it's up, it just means there's inflammation present. It could be for anything, but certainly he won't. If it's low, it's unlikely to be a problem.
Is there any benefit in repeating it once the symptoms settle, or repeating it at any point? I don't know when you might repeat it, but
if it's someone presenting for the first time, if they get better by themselves and everything goes back to normal, I'd leave it. But if it's someone with IBD, and you might say, well, I'm starting on in this course of treatment, one of the markers I'm going to look for to see whether it's effective is not just your symptoms, but actually your calprotectin. And then there are some other patients I have who don't have many symptoms at all, but they have quite bad inflammation, and I want to stop them progressing to more severe disease. So for those people, I might use calprotectin as a target for treatment, but that's sort of in a small proportion of people.
And your target is under 50, is it?
So if you've got IBD, I'll probably be okay with under 150, 200, because there's always going to be some inflammation present. So we have a slightly different normal for IBD, if that makes sense.
Yeah, great. Just around the post-infectious IBS, what duration of that could you expect that to continue for?
I can go on. I mean, it can be a long-term IBS problem, but often it will fade with time. But the patients, they just give such a beautiful history. they just say, oh, it was really good. Then one day I just got severe diarrhea and it's never really gone away. And it's just it's a classic history. And that's why if you take that history just about that onset of action, onset of symptoms, it can be really helpful in that regard.
And I just want to clarify for our listeners in terms of the exclusive enteral nutrition, that is simply Fortisip.
Yeah, Fortisip or Ensure. So if you have all of your calories that way, it is a complete diet. It has everything in it that you need, except for probably the taste and texture and all the other things you enjoy about food. But as far as a nutritional thing, it's got everything that you need in it. So they need the right calories, which again, it's going to be difficult to potentially work that out. But some patients will have done it before potentially and will be happy to do it again. So it's again, you could offer that to patients instead of steroids. It's something that can be helpful.
Great. Rich, anything from you?
No, I think you covered everything. Yeah. We've got loads of cases. Shall we keep going?
Yeah. Go, Richard.
Okay. All right. So here's John. He's a 53-year-old carpenter. He was diagnosed with UC age 30. He's never really engaged very well. He's always just had diarrhea and not really come to clinic much. You don't see much of him. He had some abnormal liver function tests recently and he presents with rectal bleeding, which is just a little bit worse than what he has previously had. So again, established UC, not great control. What might be going on? Why might he have abnormal liver function tests and how might you investigate this further? So again, I'll just give you a moment or two to think through why he might be presenting now, what else might be going on.
Just while they're quickly thinking, Richard, there was a question around, you mentioned flagell, but someone was asking around IVABs in hospital. Would you have something?
So if anyone if a patient's got perforating disease, if they've got an abscess, yes, but we wouldn't typically use it as a treatment for luminal disease as an inpatient. By that time, they'll be on IV steroids and they'll be having infliximab, and we'd be going hard that way. But if there's any sign of a complication with an abscess or something inside, then absolutely. We're very worried in that situation about using steroids. We might touch on that a bit later. Okay. Thanks. So what's wrong with this guy? Well, he could have cancer because he's had pancolitis for more than 8 years. So therefore his risk of cancer goes up above that of the normal population. He could be having a flare, or he could be having diverticular disease or any of the other reasons that are going on as well. But obviously now you've got an older person, he's got a precancerous disposition, and he's got abnormal liver function tests, which start to make us think about other things too. So what could his abnormal liver function tests be due to? Well, he could have metastatic colorectal cancer. He could have primary sclerosing cholangitis, which remember is that very pre-malignant condition that increases the risk, not just of cholangiocarcinoma, but also colorectal cancer. And if he was on a thiopurine, which he's not, he could have a thiopurine side effect as well. Or he could be a drinker, or he could have fatty liver, who knows. So how would you investigate further? He needs a scope. I mean, he's had chronic disease. He needs to be restaged. He needs to have surveillance for what's going on. And he needs a non-invasive liver screen and history around that. So he's got a cancer. And again, just around these patients are at risk of colorectal cancer. So a really important part of their health maintenance is making sure that they're in a surveillance program. It's only for colonic inflammation that we're interested in. Small bowel inflammation does increase your risk of small bowel cancer, but the risk of small bowel cancer is so rare anyway, we don't screen for it. So the risk of colorectal cancer increases after 8 years if you have pancolitis. If you have left-sided colitis after 15 years, if you've got proctitis only, there's no increased risk. So someone with a bit of proctitis, they don't need to have surveillance. If you have IBD and you've got primary sclerosing cholangitis, then you have an increased risk as soon as the PSC is diagnosed. And those patients will have yearly colonoscopies. Their risk of colorectal cancer is so high, yearly colonoscopies if you have PSC. Otherwise, if it's pancolitis, it'll be between 5 and 1 or 2 years, depending on other factors, which might include family history and other things as well. If you have poor disease control, your risk of cancer goes up. So that's another reason to motivate patients to be on maintenance therapy to avoid that risk. And surveillance for dysplasias is it's not a straightforward colonoscopy, and often needs someone who's got an interest in that to be able to do it well. They get dysplasia in flat mucosa, so it's not like a polyp, so it can be quite hard to see. Oh, that's the end of that case. So we can stop and take any questions if you like.
There was just one question from Jack Hayward, who was wondering, how easy is to access formula for the treatment of people with ulcerative colitis ulcerative colitis or inflammatory Crohn's disease?
Yeah, so if you have inflammatory bowel disease, you instantly get a special authority, lifetime special authority. So if you go to the website, it's one of the ones where there's just a list of, you have any of these, you can get it for life. So that'll mean you can get the powder for free. So the tins of Ensure you can get for free. Now, if you want to get the Tetra packs, there's a partial charge with those. So when you send the prescription into the pharmacy, they'll deliver it, but they take the patient's visa number first and bill them for it. So it depends a bit on what type patients like and what they can afford. Obviously, the Tetra packs are really convenient, but the tins of Ensure are free.
Cheers for that, Richard. And just while we've got an opportunity to ask another question, do you think there's much of a role in proctoscopy for the diagnosis of inflammatory bowel disease? And do you think there's to be something that would be useful for rural hospitals to have and for generalists to get training in?
Yeah, I mean, I think.
And GP?
Yeah, I mean, it's one of those things that if you can do it, it's fantastic. So if someone is there with you, you get an answer very quickly. That's better than a CRP. If you can see inflamed mucosa, it's going to be really helpful. So if you can do that, that's great. But the question then is, well, how often are you going to need to do it? But I think being able to examine the anus and rectum and even distal sigmoid effectively is a really useful skill to have, no matter, well, perhaps not everywhere in medicine, but in many places in medicine, it can be a really useful thing, to look for other diseases. Remember, these patients get fissures, they get perianal abscesses. There's a lot of patients who come in who have rectal cancer. Other diseases can also be identified that way. So if people are able to, yes. How easy is it to get trained in it? I don't know. I mean, I don't do rigid sigmoidoscopy anymore because I can use a flexible one, and that's easy. But and that's what I'll tend to do. But I think if you're in a situation where you don't have access to that, then clearly it's a useful thing. Or even if it's one person at your practice who could do it, the patient could come back potentially, and that would be another way of reducing or increasing the volumes for fewer people.
And it is likely something that the more you do of it, you'll get more skilled at, and so that is a good suggestion.
Yeah.
Okay, brilliant. Fourth case, Richard.
Okay, fourth case. All right. So this is Bianca. She's a 35-year-old administrator. She got Crohn's disease 14 years ago. It was ileal Crohn's disease. She was hospitalized early, had some steroids, had some azathioprine, didn't work. So she got onto adalimumab. It was Humira back then. That didn't work. So she had a bowel resection. So an ileocolic resection. They took 40 centimeters of her terminal ileum and a bit of cecum, a primary anastomosis. And then she'd been doing pretty well after that on azathioprine and adalimumab combo therapy. That's pretty standard sort of a story. Interestingly, after her resection, though, she had a lot of diarrhea, and she came back to clinic and said, "Oh, it's just like I've got my Crohn's back again." And I suppose the question is, this sort of post-operative diarrhea isn't uncommon, and I just wanted to think about for a minute why might she have post-operative diarrhea? So, terminal ileal resection, the big one is bile acid malabsorption. So typically these people will have abdominal pain, weight loss, getting worse, have an operation, then watery diarrhea. So they've actually got a very different symptoms to what they're presented with initially. Remember, after an operation, it also takes a while for the gut to adapt. So often we'll just wait and see what happens. But if we're wondering about bile acid malabsorption, a trial of Colestid, which isn't much fun to take, but it just will switch it off just like that. So if you have a patient come and see you who's had an ileal resection, you can change their lives by giving them Colestid. It's a fantastic treatment. They can't always tolerate it though. they might have active disease, or they could have any of those other things going on, and I won't touch on those. But just think about bile acid malabsorption in people who have had an ileal resection. It's something you can fix very easily. So she now presents at 9 p.m. on a Friday. She said abdominal pain for 10 days. She's increased bowel motions up to 5 times a day. She's not eating much. What else do you want to know? What other history is important? So just a few seconds to think through what other things you want to know for Bianca. So again, you want to know more about the history of presenting complaint. How quickly did this come on? Was it sudden? Is it gradual? What other things are going on in the life? What other history examination? You know, is she under stress? Is it more a functional problem? What else could be going on there? So what can you get in rural medicine at 9 p.m? And I suppose that's a question that you guys will know much better than I, but obviously objective information, you can take a very good history, you can examine someone, but getting objective information will be limited by what you have in the institution that you work in. And you know, if you can get any simple markers of inflammation, I think they're fantastic, because it'll really make you feel more comfortable about prescribing something that's going to treat inflammation. I think if you're in any way concerned about the surgical stuff, obstruction or perforation, if you can get a plain x-ray, great. If you can't, you need to talk to a surgeon and say, yeah, this is what's going on. And you need to use, if you're worried about either of those things, you need to be able to say whether you're worried about them or not to that person, so they can decide whether to take them or not. You can get point of care fecal calprotectin, which sounds like fun, but I think they'd probably go stale on the bench, given that you're not going to see this that often. But I think, again, the other sort of key things for me would be any objective markers of inflammation. If you had someone who had, if you could do a rigid sigmoidoscopy, that could potentially help as well. So there are important considerations. Remember, non-IBD symptoms. So could this be due to other things? Could it be due to IBS or infection? The surgical complications, as I've mentioned, and then IBS symptoms. So if this is a flare of disease, what could you do for this woman? She's already on azathioprine and she's on adalimumab as well. So we could go back to the devil we know. We could give her a course of steroids, a standard 40 milligrams a day, tapering down over 8 weeks. We would need to admit her if we wanted to give her IV steroids. If she was sick enough, then we might go down that pathway. The only concern we would have is we want to make sure she doesn't have an abscess. So if she had Crohn's and she had a little abscess from a bit of perforating Crohn's disease, and giving someone steroids in that situation would be not so good. So again, in that situation, if they have a fever, they're tender, you know, you might want to give them steroids, but maybe you just want to give them antibiotics. And in that situation, you're probably liaising with a surgeon, and I'd be saying, look, you know, I can't do all the tests that you can do. I'm worried that they're clearly having a flare, I think, but I'm worried they could have a small abscess or a perforation. I've given them the antibiotics. Do you want me to start hydrocortisone or not? And in that situation, they're probably they probably need to go to the surgeon if they're sick enough. But that use of steroids with, you know, sometimes you have to do it very carefully if you're worried about infection at the same time. And of course, as I mentioned earlier, you can now go to weekly Amgevita, which is fantastic. So it's good timing of this talk. It only happened a few months ago that you can now do that. So they're referred to base hospital. Yes, they've had a flare. They're discharged on adalimumab, azathioprine, and prednisone. They present again to you 3 Fridays later. You're lucky you get all the Friday nights on call with cough and shortness of breath. So what might be going on now? So Bianca, Crohn's disease, adalimumab, azathioprine, prednisone, recent flare, now cough and short of breath, differential diagnosis. So remember, she could have a clot. So always got to have a low threshold for thinking about a clot. But of course, she's triple immunosuppressed. She's got Humira, or she's got adalimumab on board, azathioprine and high-dose steroids. And these patients are at high risk of PCP or PJP. So again, thinking about what else could be going on. This is where we need generalists who can think more broadly around other causes for things that are happening. Could just be a conventional pneumonia, could be another opportunistic infection. But again, you need to be looking at this list of medications going, oh my goodness, you know, you don't have much immune function left. You know, we need to be thinking broadly about what might be going on. And often in that situation, we'll give cotrimoxazole prophylaxis. We would here anyway, not always, but often we would. So summary of this case, important to consider IBD and non-IBD causes for presentations in patients with IBD. So it could be IBS, it could be infection, it could be those other things. careful using steroids if you think they could have intra-abdominal sepsis. So if they're tender, you're really worried that they could have an abscess, there's a lump there, just be careful about that. You've got to exclude those surgical problems. And just remember the combination immunosuppression is also really common, is common, and there are complications from that. So just some take-home messages for the whole talk. I can do that, then we can do questions forever, or perhaps not forever, for a while. A thorough history, again, I think it is the key. Remember, the surgical complications is where you're going to get burnt in rural practice. So it's the perforations, it's the abscesses, it's the obstructions. So having a really low threshold to get on the phone, to get those people out to get help. It's not uncommon to have two diagnoses at the same time. So they could have IBD and IBS, IBD and infection, IBD and a drug. So again, thinking about that and understanding what you might do if you're managing two problems, not just one. You can change existing therapies, not just throw steroids at people. So you can up the 5-ASA, you can go to weekly Amgevita, you can add exclusive nutrition. There are a range of things you can do. And patients also know their disease really well. So often they'll come and they'll go, I'm having these symptoms, but it's not like my normal flare. Or they might just come in and say, this is exactly the same as I had last time. And obviously patients knowing too much is a good and a bad thing, but often they will know their disease very well. And listening to them is important, but also making sure they understand that you have to think about other diagnoses as well. So I can finish up there, and happy to take questions and carry on.
So Richard, in terms of the generalist team that you're talking to, I think you've hit the nail on the head in terms of just enhancing our knowledge and empowering us to be generalists and think of the potential complications that can occur for our team and our patients that present. There's some things now that when I see my next IBD patient, I'll be like, oh, I must think about that and that and that. So thank you very, very much. I'll hand over to you, Rich. Have you got some questions there? I know you've got some.
Yes, certainly. Got a few questions here from David and Susanna, and they're just wondering, is there any role in any diets for the control of acute flares of IBD or their ongoing management?
Yeah, so there are. So the one with the most evidence is exclusive enteral nutrition. So we'll get that off the table first. After that, there is the Crohn's disease exclusion diet, which is quite a specialist diet that's developed in Israel. There are some dietitians around New Zealand who can deliver that. But you probably would need to. The problem with a lot of these diets is they get very exclusion diets, and people don't get off them, and they can end up in trouble long term. But if you can get dietetic help, the Crohn's disease exclusion diet, we've done lots of research on low FODMAP diet and Crohn's disease, but it's not for inflammation. It's more for people who've got Crohn's disease and ulcerative colitis and IBS. It helps their IBS, but it doesn't help their Crohn's disease. So absolutely. The other ones, of course, are if people have got a stricture or obstructive type symptoms, and clearly you want low fiber diet, so they get to eat chips and no veggies and stuff, so they're lucky. And then you've got also for people who have got ulcerative colitis, you've got this conundrum whereby they probably want to go on a low fiber diet so they have less bowel motions, but actually fiber can be good for their bowel as well. So it's about, again, a healthy balanced diet is where I start, but there are a number of those different options. I tend to refer to a dietitian. I'm lucky I can do that. And of course, I've got an IBD specific dietitian who's fantastic, who does actually consult privately all around the country by Zoom. But so there are options for those people sometimes, but most dietitians are very collaborative dietitians, and if they don't know, they'll often ask other dietitians about what to do. So if there are people locally where you are, or getting them on board, but the key is making sure people don't exclude too much.
What about more fashionable options such as whole food diets or keto?
Yeah. So there's not a lot of data. So it might work, but there's not a lot of data. It's good for losing weight. I've just lost 12 kg doing keto and low calorie. It's been great, but it's there's no data that's effective for IBD.
Cool. And just out of interest, have you had to adapt your management of IDP or inflammatory bowel disease patients in the era of COVID?
Yeah, so initially we were terrified that we had all these patients who were heavily immunosuppressed. I was lucky enough to be part of a big consortium worldwide where we had over 7,000 patients with IBD and COVID reported in, including all their medications and their outcomes. And what we found was that basically steroids are bad. If you're on steroids, it's a risk factor. If you're old, it's a risk factor. If you've got IBD, it probably increases your risk slightly, but the drugs like the biologics and the other drugs didn't really increase the risk very much. At the moment, all the guidelines worldwide say if you get COVID and you're on biologics and immunosuppressants, you should stop them for 2 weeks. I think it's rubbish, because that was in a pre-immunized non-Omicron environment. We now have a mostly immunized Omicron environment, not Delta. So now patients are just carrying on with most of their drugs. So it doesn't tend to play such a role anymore. And it doesn't make sense, because the immunomodulators and biologics, if you stop them, they're still in your blood system for a good week or so, and that's when you've got COVID. So you're probably just more likely to have a flare of your IBD. So I tend to, even though the guidelines don't say that, I tend to, and most of my colleagues now, would continue treatment.
Yeah, and I think a good observation has been made by somebody around the country, Joanne, who sort of said, or one of the take-home messages I've taken from this talk is, like the importance of getting an early fecal sample in these patients with IBD to make sure there isn't something else going on. But a few people around the country, they have to wait for 7 days of diarrhea before the lab will process their sample. But I think the suggestion here is you maybe phone up the lab and explain why with the benefit of doing it.
Yeah, I mean, yeah, or if you're busy, as you guys will be, just lie on the form. So I shouldn't say that, but just I mean, at the end of the day, they've got their rules for their reasons. But if these patients have got IBD, then this is a different population. This is someone who has got a high risk of having an infection, and actually a negative or a positive result will make a huge difference to what you do. It'll be the difference between increasing immunosuppression and giving some antibiotics or doing nothing. So that's an enormous difference that the lab's making, and they should feel very proud and happy to be part of that story, I think. So I mean, they need it done, and I just do what I had to do to get it.
White lies.
I feel empowered to do that after your, speaking to you tonight. So I have no qualms in doing that sometimes, twisting the truth for the benefit of patients. So
yeah,
it's brilliant. It's brilliant. Okay. That's all, Richard, on there. Rich?
That was it from the questions.
Anyone else got any burning questions while you've got an IBD specialist on the forum?
Jeremy up in Taupo would like to know, after initial acute flare, what sort of length of time would you consider doing a colonoscopy?
Yeah, so once you've got the index, once you've got the diagnosis made, then really there's no, you've got to have a reason to do it. We've got enough trouble with not enough colonoscopy resource in the country, but even with that, you've got to decide, well, why are you doing it? So for me, if I started first presentation, not once diagnosed.
Yeah, I think that's before they've. Yeah,
okay, yeah. So that's just, there's this real difficult situation where someone presents with acute severe diarrhea, bloody diarrhea, and you're thinking, is this an infection or is it IBD? In that situation, I suppose you're going to look at CRP, you're going to look at how bad their symptoms are, and they may need admission straight up and diagnosis straight up. So I had a guy 2 weeks ago, I scoped, and he had bloody diarrhea for 2 weeks. He got a colonoscopy, but the question is, of course, is it just we say often, oh, you need 6 weeks of symptoms before you get a colonoscopy. If they're bad enough, they need a colonoscopy and need admission to hospital. It needs to happen very quickly. So that's the person I think you get on the phone to, and you say, look, I know this person hasn't had 6 weeks of diarrhea, but they're having 10 bowel motions a day. There's blood. They've got a raised CRP. I'm really worried this person's got acute severe colitis. Say that. I'm really worried this person's got acute severe Crohn's. Then it's they just get a scope and they need one. So I think that you need to probably advocate harder for them, because there's a lot of people out there who don't need a scope who've got diarrhea, but if you say those words and if you're worried this person's toxic and unwell, then I think that's where you do it. So if they've got less severe symptoms, then that can wait, then they can be done in a few weeks' time, and that's okay. But if they're at that more severe end, that's the tough one. It's hard for those patients too. The first time they ever get get IBD, they get it really badly, and some of them lose their colon. My guy lost his colon with his first presentation. That happens. It's not much fun.
That highlights the key around the importance of the information you actually put in the referrals, doesn't it? You know, some people just cut and paste what they've written in their clinical notes and, you know, say from a GP perspective, but actually putting up the key points in your referral is key.
I think if you say things like, yeah, I'm worried about acute severe colitis, if you say, I'm worried about this person's unwell, and if they have to wait too long, I'm worried things are going to get, just say it.
Yeah. And just in terms of the IBD specialist dietitian, what would her name? I think she's a he. Was she?
Catherine Wall, her name is. WALL. Yeah, so she did a PhD as well as a dietitian. Then she did a postdoc in London, and she's great. She's very, very good at that stuff, and she consults all around the country by Zoom, as well as working in research with us still. So
brilliant. Okay, well, I think on that note, we will say thank you very much, Richard and Rich, for helping us this evening. It's been very, very informative. I have thoroughly enjoyed our evening this evening, and I'm sure everyone else has. So as I say, if you would like to claim CME points and you'd like me to help you do it, just complete the feedback form and put your medical council number at the end of that. Don't put it in the chat, and I can just do that this evening. Okay, so thank you very much, Richard, on behalf of all of us.
Thanks.
Ka kite.